Hello, everyone. My name is Tiana Brown, and welcome to today's webinar, Childcare Health and Safety Updates. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or by computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. This webinar is being recorded. All participants are placed on mute for quality assurance. You will have the opportunity to submit text questions to today's presenters by typing your questions into the control panel. You may send your questions in at any time, and we will collect these and address them at or during the Q&A sessions throughout and at the end of today's presentation, excuse me. I would now like to turn it over to Kathy Glazer, VECF President.
Thank you, Tiana, and good afternoon, everyone. Thank you for spending part of your day with us today on these to get some important information and hear some and participate in some great discussions. We will be focusing today on health and safety guidelines during this kind of period of time where the Delta variant of COVID-19 is wreaking havoc, and just grateful for the chance to hear from some state leaders and experts to give us some good advice about proceeding in this era. And today we will hear from a number of colleagues. I would like to go ahead and let you know at this stage who you'll be hearing from. And Tiana, we might move to the table of contents for the agenda for today. Or Karina, if you'll move to the next slide. And then another, please. Awesome, thank you. So we'll hear first from Laurie Forlano, who is the Deputy Director of the Office of Epidemiology at the Virginia Department of Health, and from her colleague, Rebecca Tamazin, who is the Community Mitigation Coordinator for COVID-19 at the Virginia Department of Health. We'll hear from Danny Avula, who is Virginia's State Vaccination Coordinator, Megan Healy, Virginia Secretary of Labor, and finally, last but not least, Jenna Conway, Deputy Superintendent for Early Childhood Care and Education at the Virginia Department of Education. You'll see the flow of the topics that we will move through, and as Tiana mentioned, please feel free to insert your questions along the way in the question box, and we will get to them as best we can. And with that, I think I will turn it over to Laurie Forlano.
There. Good afternoon, everyone. Thanks for having the VDH team on today. We're so grateful to have the opportunity to share some information with you and hopefully field some questions. Kathy, I should probably confirm that you can hear me, right?
Yes, we can. Thank you.
Okay. And maybe just a reminder to folks to mute your lines if you can. So today we're going to try to give you an update in general. I heard there was some interest just on understanding the COVID-19 trajectory and trends that we've been experiencing and how it might impact your settings. I'm fairly confident you're experiencing some of it already, and also walk through some of the mitigation guidance. We've had great partnership with DOE throughout, so we're thankful for that, and I'm so grateful for all of you in the field who are taking care of our kids and keeping them safe. Next slide, please. Wanted to start by painting a very big picture, a somewhat concerning picture of the United States. I don't know if others are hearing that, but I think a mute line is not muted. So just reminder to folks, if you're not muted, that would be great. So this is the United States in the current moment. We take a deep breath when we look at this picture. So the entire country, with the exception of Maine and Vermont, is experiencing what we call a high level of community transmission. CDC has 4 categories of the level of community transmission, which is in the bottom right-hand corner of the slide. We also have, and you'll see it in a moment, of the Virginia version of this method as well. So Virginia, so to hit that red mark, you have to have 100 cases per 100,000 population within the last 7-day period. So a cumulative count within that 7 days over 100,000. And Virginia hit at 195 cases per 100,000 population. And you can see, we just, for illustration and comparative purposes, our friends in the deep southern states are really struggling right now. Louisiana with almost 4 times what we're experiencing, Florida, similar, and Mississippi as well. They're also experiencing very concerning hospitalizations and healthcare capacity issues in those states. Next slide. For a closer zoom in of some of our neighbors, as I said over the last week, and this was updated, this is a couple days old, this slide, but not too much change since then. 195 cases per 100,000. That was a 22% increase from the prior 7-day period. Our neighbors in Tennessee, Kentucky, North Carolina, and West Virginia all have rates higher than Virginia at the time of this slide was created. And District of Columbia and Maryland have rates lower. So we're all relatively in the same place, but some of our neighbors are experiencing more impact than Virginia is right now. Next slide. This is a view of our level of community transmission dashboard on the VDH website. So if you go to our website or Google COVID-19 data Virginia, you'll typically be taken to the home screen, and then you can click on COVID-19 data, and there will be several blue tabs and options, one of which is the level of community transmission tab. And if you click on that, you'll get to this tool. You can drop down and see your particular locality. Beneath this map on the website, there will also be 2 line graphs, one for case incidence, which is that number of cases per 100,000, and one for test positivity. The level of community transmission is driven by one or the other of those metrics, whichever is higher. Almost always it's driven by the case incidence. So this is the current picture of Virginia. There is some discrepancy between CDC and state data. Many states experiencing that. We're close but not exact to them. We're trying to figure that flow out, but in general, it's usually fairly similar, but might not be the exact same number. So when we have high transmission, what that means, simply put, is that you're much more likely to come in contact with someone who is infected with COVID-19 if you're interacting with people outside your home. Next slide. This is a view of our hospitalization data. Once the slide comes up, great. We had over 1,200 current hospitalizations, and that was a 7-day average. That was an increase. So you can see that curve on the right-hand side of the graph there. The yellow line is the 7-day moving average of the current COVID-19 hospitalizations. They include confirmed hospitalizations and pending data, just that's waiting on data confirmation. So the curve obviously is a dramatic slope, an increase, not quite as high, of course, as the January peak, and we hope it stays that way. And I think that speaks to the effectiveness of vaccines protecting against severe illness, hospitalization, and death. Next slide. Because you're all childcare providers, we'll get to make sure this is, yes, we wanted to make sure we had the childhood perspective reflected. This is CDC data. Virginia is working on analyzing our own Virginia data at a state level for age group hospitalization analysis. That's in progress. So for now, we rely on CDC. So looking at Virginia hospitalizations by age group during mid-August, so this reflects the week of, this data is current as of the week ending August 21st. The 7-day moving average for hospitalizations for people 70 and up, so older adults, was 41 new hospitalizations. And that line is that dark purple line on that left-hand graph. The 7-day moving average of new pediatric hospitalizations was 4, and it was 6 the previous week. Unlike the this is Virginia data. So what happens here is on the left-hand side of the screen, you can see a different line, colored line reflected for different age groups. On the right-hand side of the screen is a zoom in of that yellow mustard colored line, which is children 0 to 17 years of age. So you can see on the right-hand side of that yellow graph that the curve is going up for pediatric hospitalizations, although the amount to which it's going up is quite lower than the older population. Unlike the United States as a whole, the pediatric new hospitalization rate in Virginia has not reached the rate it was at the January peak. That trend is different in different states, but for now, Virginia is not experiencing that, but we will watch and monitor that closely. Next slide. Thanks. Wanted to let folks know that on our website now, we recently updated a vaccine dashboard to show the rates of COVID-19 infections, COVID-19 hospitalizations, and deaths in people who are fully vaccinated, those who are partially vaccinated, and those who are unvaccinated. So one of the images is on the screen. So when you compare rates among those three groups, that's a more accurate way to see how well the vaccine is working than, say, looking at the proportion or the percent of cases that are unvaccinated. Between January, about mid-January and August 14th, unvaccinated people developed COVID-19 at a rate 12.5 times higher than fully vaccinated people and 2.5 times higher than partially vaccinated people. As of mid-August, about 4.7 million Virginians have been fully vaccinated. Of those, 0.2% have developed COVID-19, and less than 1%, 0.009%, have been hospitalized, and less than a fraction of 1% have died. So it's an important take-home message about how powerful the vaccine is in preventing severe illness, hospitalization, and death. Next slide. Wanted to draw a little bit of attention to some of our outbreak data. We are seeing increases in outbreaks amongst all settings in Virginia. So we track outbreaks, categorize them, say, by educational settings, business, places of worship, healthcare, et cetera, long-term care. This is one analysis our outbreak surveillance team did. 36% of outbreaks that we've had in the weeks that are reflected on the slide are related to facilities for children. We're looking to compare those rates to this time last year or pre-pandemic. Some of that will likely just be natural, so to determine if it's a real trend increase. Anecdotally, absolutely hearing that we're experiencing outbreaks and disruption in general to people being because of people being quarantined in childcare settings and some school settings. So it's not always in-school transmission for your K-12 counterparts, but sometimes it's a community-acquired case that requires people to be quarantined because of contact. So we are definitely hearing those situations. We know it's disruptive, definitely trying to give advice as best we can, but wanted to draw your attention to these outbreak trends, that kids are definitely being impacted by some of these outbreaks. Next slide, please. And I think this is my last slide here. So we wanted to talk a little bit about Delta. So Delta causes more infections. It's known to spread much faster than earlier strains of the virus. It is known to be more contagious. And some data suggests that the Delta variant might cause more severe illness than previous variants in unvaccinated persons. We know that the COVID-19 vaccines authorized for use in the United States are highly effective at preventing severe illness and death from COVID-19, including against Delta. So the greatest concern right now in this moment is for people who are unvaccinated. Fully vaccinated people can can experience a variant or Delta breakthrough infection, and some can spread the virus to others. However, data is showing that vaccinated people appear to be infectious for a shorter period. So still, those vaccinated people, it is possible that they can become infected. It's a much, much smaller proportion as compared to unvaccinated. But at this critical point in the pandemic, I think what we're learning is until we get more of the population vaccinated, what's happening is that the Delta is really working its way through these unvaccinated groups of people, and there's not enough vaccinated people to create that buffer. So really, again, hitting home the importance of vaccine. CDC is also emphasizing messaging that vaccine in this moment, the amount that we have, vaccination rate, that is, people who are vaccinated, is not enough alone with this surge. We need other mitigation strategies, testing, masking, etc., to really keep this surge at bay. I'm hoping my colleague Rebecca is on now. Hopefully she was successful. Are you on, Rebecca? Not sure if she can get in or not. If she's not, I can just.
Yeah, Laurie, I think she wasn't able to get on.
Okay.
And I see that it
No
looks
problem.
like Danny Avula has been able to get on, so he'll be able to continue on once you're finished.
Okay, I'll go through the remainder of the content as best I can. Why don't we move on? So just wanted to review some of the CDC guidance for early child care education and child care settings. Together with us, public health, child care administrators need to, as you have been, need to consider multiple factors when implementing layered prevention strategies. So the things and I know all of you have been considering throughout the pandemic, is what is the level of community transmission? So we earlier reviewed where to find that on our website and how to interpret it. What is the vaccination coverage in the community? And if you know it, amongst your staff and the children you serve, you can use proxies just about the communities that you serve. And I think Danny will elaborate on some of the more vaccine information later. Are you seeing outbreaks or increasing trends of cases in your child care program or in the surrounding community? Are you aware of the health system capacity in your community? And that's typically either through anecdotal information, word of mouth, or talking to your local health department. And we also need to think about the ages of the children that you serve and just their natural behavior, etc. I think Rebecca is on now. She's texted me. Is that correct, Rebecca? She's having technical difficulties. Just keep going, Kathy. The world of Zoom. Okay, next slide. So really want to emphasize the importance of layered prevention. Promoting vaccination is one important, the most powerful tool we have to end the pandemic. But right now, particularly during this time of increased transmission, really need to think about all these other layers, regardless of whether they're required by law or not. It's important to understand the public health recommendations. These include consistent and correct mask use. I'll elaborate on that in a minute. Physical distancing and cohorting where that's possible. I understand physical distancing in an early childhood setting is not always practical or feasible. We understand that. Ventilation is a key tool that we've learned throughout the pandemic, helps decrease transmission. Hand washing, respiratory etiquette, and so grateful for all of you for encouraging those behaviors in these young children for a whole lot of reasons, not just COVID-19. The importance of staying home when you're sick and getting tested according to our recommendations is incredibly, it sounds basic, but it really is one of the most important ways we can decrease transmission. So having policies and just creating cultures that encourage that adherence to that behavior is a recommended tool. contact tracing in partnership with your local health departments, and of course, regular cleaning and disinfecting. Next slide. So the VDH mask recommendations. Mask use is strongly recommended for everyone aged 2 and up, indoors, in childcare and early education settings. And we're making that recommendation right now because there is substantial and high transmission throughout the Commonwealth. Masks are required per a federal rule on school buses. They are required at K-12 schools in Virginia per the State Health Commissioner's public health order. Staff in childcare settings are required to wear masks per the Department of Labor and Industry standards. So there's a few pieces and parts there. They can be confusing to interpret. So we just wanted to make sure we communicated that clearly. Outdoors, we get a lot of questions about this. In general, it's less important for a person to wear a mask when you're outside. The risk of transmission is lower when you're outside, generally speaking. However, if you're in a crowded outdoor setting, or if you're participating in activities where you might have sustained close contact with others who aren't fully vaccinated, it's also recommended that you think about wearing a mask. Reminder that children under 2 should not wear masks, obviously not worn where they're swimming or playing in water. We do get questions about nap time. My understanding of the recommendation is that do not mask while they're sleeping. And I think that's on our website. And when possible, masks should be provided to students who need them if they don't have their own. Next slide. So although our VDH contact tracing guidance that's on the screen is entitled that it's specific for K-12 schools, the same general principles apply to children and staff in childcare settings, whether they're in a center or a preschool or a family day home. The childcare programs and facilities that all of you represent today can consider following CDC and VDH guidance for K-12 schools to walk yourselves through what to expect when a contact investigation is underway. The one caveat to this is that the close contact definition has an exception that is exclusive to K-12 school classrooms that does not apply to childcare settings or pre-K classrooms. For close contacts, VDH continues to recommend 14-day quarantine as the safest option for the duration of quarantine. However, shortened quarantine policies are available as options, either 7 days with a negative test or 10 days with no test. And we understand that there may sometimes be differences in implementation of those policies around the state. Sometimes that is due to different variables at play, levels of transmission in the community, the certain context or situation, the outbreak itself, etc. And lastly, I think this is my last slide. Although we certainly try to avoid, I just want to go to the next slide. We certainly try to avoid the full facility closure. We really try to avoid that significant action if it's possible to avoid. And hopefully a closure of facility because of an outbreak won't be needed. We try to really be focused and precise on case investigations and contacts identified for quarantine to the extent that's possible. However, the impact on a facility and your operations is really going to have to be assessed by all of you in consultation with us. We can certainly provide data and information and context and prevention recommendations, but how you're operating your facility and if you have enough teachers, et cetera, that's not going to be context we're going to be able to provide for you, but we definitely want to be partners in those decision-making processes. If you have sick persons and contacts that can be excluded without affecting the larger group, then the other groups in that facility who didn't have close contact can continue to function as they normally would with daily screening, et cetera, and other mitigation strategies. So hopefully all of that has been captured in the link to the guidance document on screen. And I'm not sure how you're handling questions, Kathy, but I'm happy to pause now for
Thank
questions.
you. Lori, really appreciate that. So much great information. Just because of his time constraints, we're going to move on to hear from Danny Avula now. And if you can, I understand you have, at some point you're going to need to go, but I think once we've heard from him, we'll address questions that have come in. Thank you so much. Really appreciate that. And Danny, welcome to you. Appreciate your taking some time to be with us today and looking forward to hearing from you.
Hello, everybody. All right, I'm on now. Can you hear me?
We can hear you now. Thank you.
Okay, thanks. I had Karina behind the screen was doing a lot of, well, great to be here with you guys. And let me just start by saying thank you. This has been a ridiculous year and a half. And I, particularly last year when I was more in my local health director role, talked to lots of early childhood employees and kind of navigating all of the uncertainty and anxiety of what this pandemic has brought. And I just know, hearing the stories and the questions, this has been really weighty for all of you, and the service that you all are providing to our society is just absolutely crucial to parents being able to work, to kids being kept safe, and I know it's been really hard, so thank you. Lori really laid out a lot of the meaty part of what what public health interventions we can put in place to stem the spread of infection, and she touched on kind of the high points of the Delta variant. It's much more contagious than previous strains. I joined a little bit late, so I don't know if she hit, and I imagine some people have questions about severity in the pediatric population. I can tell you kind of what the national data is showing, which is that we are currently experiencing the highest rates of pediatric hospitalization due to COVID that we have at any point during this pandemic. I think largely that is a function of exposure, and we're not yet certain that it's any kind of increased virulence of the Delta strain itself. I think just compared to last summer, society was on lockdown, right? Kids were not in school, they were not in summer camps. And so now that we had this really delightful period of the end of May, June, and the beginning of July, where things started to feel normal again, people were getting out, and that in the face of a much more contagious variant has led to some pretty rapid transmission nationally and locally. And so, one theory is that it's just increased exposure has led to more kids getting infected and therefore more kids getting hospitalized. There's also some hypotheses around co-infection. So right now in the southern part of the US, RSV, very common virus in young children particularly, is really surging. And so, is it possible that RSV and COVID are somehow co-infecting to increase hospitalization rates? So we don't really know, but it is a real phenomenon that's happening in places like Florida and Louisiana, Texas, Arkansas. And what we're hearing anecdotally is that it does look like more severe lung disease. I mean, we've had kids in the hospital over the last year and a half who've tested positive for COVID, but really hardly ever seeing kids who were in the hospital because of COVID. They were there for an appendectomy or some other reason, and because we screen all those kids, turned up some positive COVID kids. But that's starting to change. And even though this has not hit Virginia significantly, as far as we can tell, we're not seeing a huge uptick in pediatric hospitalization due to COVID. It is looking different. We're seeing older children, 10 to 15-year-olds who are getting COVID and are having more severe respiratory symptoms because of it, who are getting hospitalized. So more to come on that. I think we really need to look at that data, better understand what's happening. But it is a trend that, particularly in the southern states, seems to be emerging. That hasn't really borne out in younger children yet, and so that's encouraging. And as Lori was talking, obviously their vaccination is going to be the mainstay of sort of our broad public health approach to preventing the spread of this disease, but that's less relevant for the student or the child population that you all care for. And so a couple notes on that. right now, our vaccines are approved for 12 and up. Pfizer has said consistently, throughout their clinical trials over the last couple of months that things have been going well. They've been testing that age group with a smaller dose of the vaccine, a 1/3 strength of the dose as compared to what adults and 12 and ups have been getting. And that's part of why it's taking longer, because they've had to really work through dose strength. And so they anticipate submitting their data for the 5 to 11-year-old age group in September. What does that mean? I mean, it means in a dream scenario, we could see an approval at the end of September if they get their data in early. More likely, it'll be sometime in October that we have an approved vaccine for 5 to 11s. Now, kids younger than 5, who are much of who you all care for, I think those trials are going to take even longer, because they're really having to work in smaller groups at different dose variations. We probably will not have an approved vaccine until the very end of 2022, or 2021 or early 2022 for the under 5 down to 6 month age group. So we'll continue to watch for reports from the manufacturers and certainly pay attention to the FDA's review of data and kind of their approval process. But everything we're hearing is that for the youngest age group, we're not going to see a vaccine for a while. So what are our options? I mean, I think for you all, for your staff, ensuring that as many adults are fully vaccinated as possible. And, in the pediatric world, we talk about this as a cocooning strategy. When kids aren't old enough or there isn't an eligible vaccine for younger children, we want to make sure that all of the adults and people who are eligible around them are protected to create that cocoon. I think there's a couple of things that means practically for you all. The encouraging of your colleagues and your teams to get vaccinated, and perhaps even considering requirements. Certainly a lot of employers are moving in that direction. As you probably heard earlier this week, the FDA finally approved the Pfizer vaccine for a full license. So it's been operating for the last few months under an emergency use authorization. It is now fully licensed, just like many of the other medications and vaccines that the FDA approves. And that full licensure has actually resulted in even more requirements by employers. And so we were seeing a lot of that in May and June, and even more now because of the full licensure. I think the other implication it has for your staff are really to pay attention to what's happening with boosters. So last week, the federal government put out new information about the waning immunity. So over time, the decreased strength or decreased ability of the vaccine to protect against COVID. And, we'll see what the final data review looks like. The Israel studies have shown that you start to drop off at about 6 months. Some other studies have said maybe that looks more like 8 months. The fact of the matter is that there's not going to be a consistent answer for everybody, right? Everybody's immune system works differently. It's going to, either hold up strength or drop off, decrease its strength at different paces. And so what the federal government has tried to do is kind of make an easy middle of the road recommendation of 8 months after your second dose, you would now be eligible for a booster shot. Now, that is all contingent on the FDA going through its review of the data, giving its approval, and then the CDC adopting that as well. So there's a lot of steps that still have to happen around that announced September 20th target date. So it's not set in stone. And I think it's also really important for people to remember that, even when the CDC does make its recommendation, there's nothing magic about that 8 months. It's not like all of a sudden your immunity drops to 0. Everybody's going to, again, decrease immunity at different rates. And so we will have a recommendation, and people will sometime after that period, it would be a good idea to go and get boosted, just to make sure that we're maximizing protection, and again, trying to create a cocoon of safety around younger kids who can't be vaccinated. But as Lori said, the strength of this really relies as vaccination is part of this, but all of those other layers of mitigation that you all have been well practiced at because you've been doing it for the last year plus. So happy to go to questions for either Dr. Villano or I. I can hang for probably like 15 minutes, Kathy.
Thank you, Danny, so much. Really appreciate it. And there are some questions that have come through in the question box, and some I'll just toss to you, Danny, and some to Laurie. We also have Megan Healy, who will be next on the panel, and she'll talk a little bit about employer decisions around vaccination mandates for staff, et cetera, from the sort of the labor law perspective. And I will ask you before we let you go, Danny, just for your sort of best advice from the health perspective on that. But first, you had mentioned RSV, and we had a number of questions around the interrelationship between RSV and COVID. Can you elaborate on RSV and COVID co-infecting and precautions to take?
Yeah, well, we don't know enough yet. I mean, RSV, as some of you probably know, is the most common virus experienced during childhood. It's the most common reason that young children, kids 2 and under, get hospitalized. And really, by the age of 2, 98+% of the general population is going to have been infected with RSV at some point. We saw a lot less circulating all types of respiratory virus last year. I mean, flu was basically non-existent because we were on lockdown, right? People were not seeing each other. There just weren't many opportunities for people and kids to transmit that disease. And now we're in a different scenario. What we're seeing is RSV rates really emerging again in the southern states, particularly. Haven't seen that pattern here as much, but it's early. Right now we're in August, and typically RSV isn't ramping up until late September, early October. So I think the interplay is something we just don't know enough about at this point, but could be part of the explanation of why we're seeing this different pattern of disease and hospitalization. But we'll see what the data shows.
All right, sounds good. And next, you talked some about vaccinations for younger children and sort of needing to wait on that. What are your thoughts in general about it? What might be the possible long-term effects from it?
So I think the question of long-term effects has consistently been a question, from the time that these vaccines rolled out back in December. Given the reality that COVID has only been around for a year and a half and these vaccines have only been out and in use, knowing long-term effects is really challenging. I mean, I think some of the basic information we can look at is that the ingredient list for these vaccines has been really streamlined. And so, and we've used those ingredients in other vaccines. The mRNA platform, while this is the first really successful vaccine that we've been able to use that technology in, it's been in evolution for over 20 years. And so and then generally the way that vaccines work, it's, you're presenting a protein or some invader to your immune system, and your immune system is doing the work of responding, of revving up, of defending your body against that invader. And it's why when we get a flu shot or a COVID vaccine, you start to feel some of that. You have a fever, you have some achiness. That's the work that your immune system is doing to respond to this invader. And priming your immune system to do that makes it much more capable of fending off a future invader if you were to actually get presented with COVID or infected with COVID again. So, I think we have a lot of information about vaccines writ large, more information than people realize about the mRNA platform. And again, because the ingredients around this particular COVID vaccine have really been streamlined, we don't anticipate seeing any long-term effects. And most serious side effects that come from the vaccine are typically identified within the first 2 months of administration. And obviously, we've had much more than that to look at now.
Awesome, Danny. And I'm going to ask you another question and then ask you to sort of conclude with your best advice to any adults or eligible age children And, what's your best health advice around vaccinations, recognizing that everybody has a lot to consider, but just in this era, give us your best shot. But first, one person said it's a sad question to ask, but you mentioned hospitalizations are increasing in children. Are you seeing terminal cases, and what kind of a percentage?
Yeah, very rarely. We have had a handful here in Virginia. And typically what we're seeing, there's not a lot that we can share, both because they've been so rare, but also because of, identifying information. I'll say one thing that when that happens, when there's loss of life in the pediatric setting, more likely than not, there are a lot of severe underlying conditions that are contributing to that, and COVID happens to be the infection that kind of takes it over the edge. I have been thinking a lot about this because, we had a recent announcement of a death in somebody 0 to 10 years old, and that raised just tons of concern and anxiety for our school-age children, their parents, and obviously you guys. And so I think there's wisdom in trying to have those families able to tell their stories in ways that we can't because of privacy laws. So we're working to figure out what are the best ways to characterize those very rare occurrences, so that we can accurately convey risk. But maybe the broad brushstroke answer I'll give is that those instances are very rare. They typically have a lot of other things going on. And for the vast majority of the population, those are not outcomes that we need to be terribly concerned about with COVID. So I'll kind of give my parting thoughts around this, and the big thing I'll say, which I don't know if it's encouraging or not, but COVID's not going away anytime soon, right? We are going to have to learn to live with this disease and future iterations of this disease. And we've already seen that in the last year and a half, as we've seen the virus trying to survive, creating new mutations, and those mutations affecting our population in different ways. Our fastest and most effective way to progress beyond where we're at right now is to get as many people vaccinated as possible, because the more people we can get protected against this, the less opportunity there is for outbreaks, for spread, for severe disease in our community. And so that eventually will be all kids, and we'll have to wait for those vaccines to be approved. But in the meantime, having as many eligible 12 and ups fully vaccinated and then boosted, if that is the recommendation that comes in September. I also think that what does the future hold? And again, it's totally speculative here, but at some point we will have enough of our population either fully vaccinated and therefore protected against the severe consequences of this disease, or will actually have been infected, right? They'll have had COVID and have developed some degree of natural immunity, where we'll stop seeing this cycle of outbreak happen. The big caveat there is, what's the next variant going to do, and is it going to evade our vaccines? And who knows what the future holds there. But I could see sometime as we get over this winter hump, things starting to settle down. We're going to see COVID, we're going to have cases of COVID, but enough of the population will be protected where we no longer have to worry about hospitalization and death to the degree that we've experienced over the last year.
Danny, as always, thank you so much. We really appreciate hearing from you and answering so many questions. And I think we have a couple more that I'm going to just try to catch Lori Furlano before she needs to jump off the line. And then Megan, it will be your turn. And thank you for hanging on for us. Lori, a couple of questions are, people are asking questions about the kind of the quarantining guidelines and the, how to make good decisions about sort of how many days, et cetera. Anything in general about quarantining that you would recommend?
Yeah, that's a good question. So the first thing that comes to mind is work with your local epidemiologist and health department, which I'm sure all of you are, but I want to lead with that. I think there's a few things to consider there. Public health, we do tend to lead conservatively with things like quarantine guidance, particularly in times of a surge like this and increased transmission. We would also consider the population, et cetera. So what we always start with is 14 days is best. Some local health departments do recommend that consistently. Others will have an approach of a more case-by-case or contextual approach, depending on the outbreak setting, the population surge, vaccination rates, etc. So 14 days is best, but those other options are available to you. 10 days with no test, 7 days with a negative test that's taken on or after the 7th day. So it is a bit of a judgment call, and but please talk to your local health departments about this individual situations.
Thank you. And just one more for you, Lori, before you go. We've had someone say that they are not able to find disposable masks for children 2 and up. Generally, they can find 4 and up. Are you aware of ways to access masks for younger children?
I am not personally, but I can, if you can get me the name of the person, Kathy, we can loop back to them. Also reaching out to your health department, sometimes they can reach out to their emergency planners in the community who can help research those questions.
Excellent. Thank you for that. We'll do that. Thank you again so much for being with us today. Really appreciate it. Next, we're going to turn to and hear from our Secretary of Labor, Megan Healy, who is going to be addressing some questions we've received over long periods of time around what is guidance for child care employers and programs who, need to understand the, legal and kind of moral implications of requiring their staff to be vaccinated. Megan, thanks for joining us today.
Great. Thanks so much for having me. And thanks for welcoming to this webinar. I will tell you, there's a disclaimer. I am not a lawyer by training. I think I've told you many times before, but I do work a lot with a lot of lawyers at corporations and employment lawyers, as well as worker lawyers to learn about the laws and help support the laws and build policy around laws. So please do not say, I would tell you as my disclaimer, if you have any questions at all, please consult your own counsel and not say that Megan said it. A couple things I want to walk through is looking at employers. So I do talk to employers daily about vaccine requirements, if it's mandates. There's two types of strategies that you can think about as an employer. And then I'll walk through myself as an employer. So I oversee 3 different agencies, a couple thousand individuals, plus some contractors, as well as I was part of the team that mandated vaccines for state employees. I do want to thank Dr. Fulano and Dr. Avola were also part of that decision making. They've been amazing support for the Commonwealth, especially with the vaccination efforts and just making sure that all Virginians are safe. So I really appreciate all their work. It's great to be on a webinar with them. A couple things, and then I'll answer some questions. I think there's 2 approaches. One is a carrot approach, which is what are some incentives, and I'll give you a couple examples of that. And then one is more of that stick approach, and that would be a mandate. Or it could be not quite the mandate, but it could be if you're not vaccinated, then we're going to make your life as a little more difficult as a worker because you're not vaccinated. So first, just a couple things around that incentives that we've seen businesses really do well. Incentives. So some workers have received a small amount of money, if it's a gift card, if it's on their payroll, if it's in cash, that they have incentivized vaccinations. That's a good thing. Sick leave policy is one of those things that some people do not feel well after, specifically their vaccination or second vaccination, so that individual will get a free day off or part of their sick leave if there's no sick leave policy in employers. Others is paying mileage. So any other type of incentive, mileage or overtime pay or pay while someone's getting vaccinated. So those are also different types of incentives. Some businesses have had lotteries. So after they know who's been vaccinated, they have special prizes for those individuals in the company. If it's vacations, I've seen to $1,000, and that would be up to the individual business for lotteries. Other encouragements is to work with their local health departments on on-site clinics. We have found that on-site clinics have been effective. Thanks to the VDH, I had one at my call center in Southwest Virginia, and it was almost peer pressure, right? So we see some people get vaccinated, you're not sure. But you actually pick up a lot more employees if you have those on-site clinics, or you encourage people to go together, a little bit of that peer pressure, so you're not forcing for vaccines, but try to encourage that. And each health district looks a little different of how they do on-site clinics, or they definitely can connect you. A lot of our pharmacies will do on-site clinics as well, so not quite the VDH out there, but it could be a local pharmacy that can come out and help do vaccinations. We always like, when you're doing those vaccination clinics, offer free lunch, ice cream, food. Again, incentives, fun prizes on those days also helps incentivize employees to be vaccinated. And really just overall awareness. We have a toolkit that business can use. If you don't think, we have Dr. Bull and Forlano, no vaccinations up and down, but if you don't feel comfortable with that, we actually through the VDH have slideshows, we have stamps, we have stickers that say I'm vaccinated, a whole toolkit that I'll send over the link to Kathy about, that you can go and you can flip through the PowerPoints, and it explains why it's important to be vaccinated. And it's all through VDH, and it's well marketed and branded, so it's really exciting to do. Quick about mandates. When we were debating, do we have a mandate for state employees, which is around 110,000 employees from the largest employer, federal government's the largest, and they're also looking, they also have mandates. We're the second largest employer in Virginia. We had a lot of internal discussion. The first thing we did is, if we mandate this, what does the court say, right? So what are the laws? And we were watching a lot of case law since this is fairly new. It's not new to mandate a vaccine. Healthcare has been doing it for years. Health systems, especially around the flu vaccine. Croydon's a great example. They have about 20 people a year. I asked them who refuse to get the vaccine, and they are fired. But there's also accommodations that I'll talk about quickly, but mandating. So we had to say what's case law, because we don't have any laws around this. All the cases so far that have gone through court and have been completed in court actually rule in favor of the employer, saying yes, employers can mandate vaccines for the safety of the workers as well as the general public if they're public facing. So that was encouraging for us to mandate a vaccine. We also looked at what are the rules. There's ADA rules, right? So if someone has a medical condition, can they be exempt from requirements? And what does that look like in the workspace? That we know that you have to provide accommodations for anyone, but those accommodations can't change the terms and conditions and privileges and promotions of employment. That is the EEOC law as well as the Virginia law. And so we had to look at what does that mean, and what is medical conditions. There's also in Title VII, EEOC is religious exemptions as well. And so if you are requiring a mandate by federal law and state law, which aligns to federal law, those are two exemptions that you have to be able to accept, and then work with those individuals around the mandate. Now, there's also a possibility that you're not mandating a vaccine, but you're making life really hard. If you've seen in the news, Delta Airlines as an example, they haven't mandated the vaccine, but if you're not vaccinated, you actually have to pay around $200, I think it is, per month, because we know that the bill, if you're in the hospital with COVID, it's around a $50,000 bill. And so Delta was like, with our health insurance, we do not want to be paying that. So they've actually had their individuals come out saying you have to pay to help support your health insurance. Others, like the state of Virginia, that we are requiring, if you do not are vaccinated, we're not asking why. So we're not asking religious reasons, we're not asking medical reasons, but you can show us your vaccination card, and we take that in a secure way. And then, of course, we copy and we have it locked, following HIPAA rules. But if you're not vaccinated, then you're required to be tested once a week. We do have a law in Virginia. It's very similar, because people are like, COVID test, like, how is this in the law? We are interpreting this as somewhat similar to drug testing. So if you are familiar with drug testing laws, we actually have in-state code that an employer cannot make an employee pay for any medical examination required for employment. So we're counting that. That's like a drug test. It also falls under that. So COVID test. So thank goodness COVID tests are free, still free. So there's no out-of-pocket expense to get a COVID test for a weekly test. We are still working on, so that has to be required. talking about like overtime pay and mileage. Other states like California requires that the employer has to pay the mileage to and from the test. We're not doing that here in Virginia. We're just requiring that they have to demonstrate they have taken a test a week. And if they do not do that, then we have that discussion about, are those individuals fired? And employers in Virginia have any right to hire or fire. The government is not telling an employer who they can hire and who they can fire. So they have a right, pretty much a right to fire anyone they wish under circumstances besides types of discrimination and other potential retaliation laws in Virginia. So those are some of the things. We have heard some people test daily. Especially in our health systems. We do have some health systems that are mandating vaccines, other health systems have not, and some health systems will be coming on board to mandate it since Pfizer was just fully approved. There was some legal question around FDA full approval, not emergency approval, but now I think a lot of businesses said when that's actually fully approved, FDA approved, we are going to mandate vaccines. And then also just as a reminder that we also had to weigh the workforce repercussions is something to consider. Is if you are mandating certain individuals that you know they probably will not get vaccinated or not going to do the test, then people will quit their jobs. And so we had to look at our different groups and populations of state employees that might quit. And really make these considerations. We've seen a large, I think it's Valley Health is mandating. They're still not there to the full mandate, but they have had a lot of individuals that have not shown that they've been vaccinated. And so they're trying to walk through, do they want to lose nurses? They've already lost a lot this past spring. Other health systems said it's not actually their nurses, it's their janitorial staff or their support staff. And so that's one of those considerations that we really thought through at the state level about, are people going to get up and walk out and quit on us? And then what are we going to do with that? And so I just wanted to say that's definitely a consideration about which path that you choose. So that's just kind of a breakdown of kind of our decision tree of how we got there. There's also one that has not been in court, but there's the National Labor Relations Act, and that does say that a worker that feels threatened at work or to do something they do not believe in the interest of their health that they do not have to do. So that has not stood up in court yet, but that could be a defense of a worker that we have not seen pass through court.
Megan, thank you so much. Great information. And you touched on a question or a consideration that I think is really valid, especially for this industry and this workforce of, employers, childcare employers and programs are really struggling to recruit and retain staff. And, we all need teachers in childcare classrooms so that, parents can get to work. And so I think that's probably a really challenging thing to weigh with, all of the benefits and the wisdom of requiring vaccinations. So, it sounds like what you said today is ostensibly it is legal to mandate vaccinations. There are plenty of ways that employers, if they choose, can incentivize vaccination, can make conditions a bit more difficult, or put back some of the expense or responsibility, the onus back on the employees who are choosing not to be vaccinated. Anything more that you would say, especially in the situation of really needing to retain staff, but also recognizing the health importance, the health perspective of vaccinations?
Yeah, it might be good. So you can ask staff members, obviously, if they've been vaccinated or not, as a self-attest, right? Or if you're showing any type of, they'd show you your vaccination card. We have some employers that just look at it and check you on a box. They have an Excel sheet that's locked that says check yes or no. Others are holding that information. So you first might want to know or figure out, you might already know, because I bet parents have asked you as well. And obviously you cannot tell parents who and who has not been vaccinated. You can say percentage of my teachers have been vaccinated, just as you're aware of that. But it might be a first to see who's vaccinated, who's not, to know, are you going to lose employees? Because the workforce is important. That was probably our toughest decision, to say, are we going to have people walk out in certain fields that we know are not vaccinated? A lot of public safety individuals, which are in our rural areas, is where we've struggled the most, I think, for state employees. So And so I think, having a quick self-attest, are you vaccinated or not? How can I help you get vaccinated? Education and encouragement, peer pressure is a really good start. And then if you see if it's a huge issue, then you can start contemplating like others. But I really think in the childcare, I would really examine your workforce needs and make sure that you're not going to have individuals walk out.
I appreciate that. And one thing that I've noticed too is that, especially in my own organization, is many of our employees are really anxious to make sure that others working around them are vaccinated. So I think there may be just as much of a need to think about those employees as well. Danny, looks like you want to weigh in.
Yeah, and then I'll leave. But I think one of the things we've seen, at least nationally, I don't know how this would break down with this particular sector of employees, but the impact of requirements has been less than you might think otherwise. So I'll give the example of Houston Methodist, which was the first health system to move to a requirement. And they anticipated, both because they were on the front end of this, so this was back in like April, that they would lose somewhere between 10 and 20% of their staff. They've got 25,000 employees, and at the end of the day, lost 140 total. And so I think in some ways, this is just becoming more and more of the norm, especially now that the FDA has fully licensed this vaccine, and that the data is so compelling against protecting, around protecting against hospitalization and death. So I do think it's going to just become more the norm. And I think in this sector, the more employers that are actually sort of going down this road, the less likely it will lead to people leaving. And in some cases might actually give them the push or the cover they need, right? We all are part of different social circles that kind of tell us different things about whether we should or shouldn't get vaccinated. But if an employer says, hey, you've got to do this, that might be a reason that people feel okay about getting it done.
Awesome. Thank you. Thanks, Danny. We will let you go. I promise. Thank you for working with us. Megan, one last question. I know you said you're not an attorney, you're not giving legal advice, but we think you're, number one rock star. So one person has asked, when hiring, is it legal to ask if someone is fully vaccinated? And if not, is there a way to address that?
I think I'm not a lawyer, and that's probably a question I can ask to my lawyer friends. I think that crosses the line. So if that person, let's say there's two candidates and you ask that question and the person that's not vaccinated did not get that, I think there's a legal challenge to that question of saying that I did not get a job based off of medical. So it's one of those questions I would hire the person first and then ask the question, because I think someone can pull ADA and say it was because of a medical issue that I was not hired, and that's against EEOC.
Okay, great advice. Thank you, Megan. Really appreciate your being here with us.
Thank you.
Much appreciated. Thank you. Now we're going to turn to Jenna Conway at the Department of Education and hear from Jenna. Jenna, it's up to you. And Karina, I think we'll bring up Jenna's slides now. There she is. Jenna, let's see if we're hearing you. Can you hear me, Jenna? Jen, are you able to hear me? Karina, it looks like we need some troubleshooting with Jenna's audio.
Hey, Kathy, can you hear me now?
Yes, hooray.
I've also lost sound. Can you hear me, Kathy?
Yes, we can hear you.
I'm going to log out really quickly and try to come back in. Hold on one second. All right, I cannot hear you, although apparently you all can hear me. So I will go through, and then Kathy, if you want to either text questions or we're probably pretty close on time anyways. But I'm Jenna Conway. I was not having any problems at all for the first hour of this. And of course, Murphy's Law is the moment that I have to speak is when my system stopped functioning. But I'm our Deputy Superintendent of Early Childhood Care and Education at the Department of Education, and I'm very pleased to be here. Luckily, I was able to hear all of the other presentations and the questions asked by the audience, and this has just been such an informative hour. Thank you so much to my colleagues at the Department of Health, as well as our workforce advisor. I know this is such a challenging time, and I'm deeply appreciative of learning all that I've learned in the last hour. I also want to extend Dr. Avula's appreciation for the field. I cannot believe we have been at this for so many months. I know folks are exhausted and just so frustrated that this continues to go on. I think, as Dr. Avula noted, this is with us for a while, and figuring out how to survive as we recover is so important. But I know it comes with some costs, and just wanted to note that I've had the opportunity to be out in the field over the course of the last few weeks as school is returning and as folks are returning to in-person Head Start, childcare, and there's so much excitement, I think, about kids being able to be back with each other. And so it's even more frustrating that Delta is raging back and causing barriers from kids from accessing in-person learning and care. Next slide, please. What I'd like to wrap us up with today is taking us through the implications for early childhood care and education. We have received so much information in the last hour and just wanted to bring us home with a focus on what this means for you as an early childhood care and education provider. I want to note that Delta comes at a most inopportune moment, that across the state, you all, whether you're in a home setting, a childcare setting, Head Start, or schools, are trying to get back to in-person. Some of you have been doing this, like our incredible Family Day homes, the entirety of this pandemic. Some of you have closed and have reopened, and others are just fully kicking back into in-person, and yet Delta is causing these disruptions. One of the clear things we learned from last year is the importance of in-person, and we just know all of the data from what we've heard from families and what we know from looking at the impact on kids is that there is no substitute for in-person early care and education. And so we know this is so important to figure out how to do this safely for kids. We also know that our families rely on you as they have to work. We have guidance both for schools and for childcare and Family Day homes. Talk a little bit more about that. We will continue to adapt, evolve, and update that guidance as we learn more about Delta. It was good to hear from our partners today. And again, we seem to be at a moment yet again where things are pretty rapidly moving. And we at the Department of Education will do our best to take that updated information and get it out to you. Next slide, please. So just as a quick update, many of you know that we moved responsibility from childcare to the Department of Education as of July 1st, and we have begun putting out updated guidance for childcare programs in both English and in Spanish on the Childcare VA website, which will also make sure, I think, that has been sent around as well. Our most recent guidance focuses on many of the mitigation strategies that Dr. Fulano talked about: masking, distancing cohorting where possible with young learners, and then screening and testing. And so again, this should look familiar to you. If not, please take a look. Our last update was on August 13th. So make sure that that's the copy that you have. A lot of this is guidelines. Again, this is moving so quickly that the best we can do is provide these guidelines, and you can always email early childhood, that's one word, and I'll ask them to put this in the box as well, early childhood at doe.virginia.gov if there's any questions. Next slide, please. The key point, I just want to summarize the point on masks. So this is just a quick chart that covers where folks need to be masked and when they don't. Some slight differences across our settings, across the board. I just want to emphasize that masking can be very effective. Needs to be for children 2 and up. As you see in most settings, masks are required for staff, and in most settings, and in all settings, not appropriate for under 2. And then you see some variation depending on your setting as to whether they're required indoors or whether they're strongly recommended. So again, in our schools, due to the public health order, they are required for all children 2 and up, and they are strongly recommended in our family day homes and child care centers. And then they're required again on all transportation. So just, I know we've gotten a lot of questions. I know the Department of Health has gotten a lot of questions. Just wanted to summarize in one place what the requirements are based on the setting, whether that's inside in a particular program or on transportation. Next slide, please. I want to talk a little bit about vaccinations. I know we've talked a lot about that, but as it relates specifically to what we know about the early childhood care and education setting. So this is some hot off the presses data from surveys across the state, specifically of early childhood educators. So you've heard some information from Dr. Avula, you've heard some considerations from Megan Healy about how to think about what you might want to do for those of you who are employers on the phone. And you heard from Dr. Ferlana that we know that these vaccines are safe and can significantly reduce the risk of hospitalization and serious illness. So what do we know actually about our workforce? So we do know, based on a survey that was completed in July and August, that roughly just under 70%, so 68% of our early childhood educators are fully vaccinated. And that our family day home educators are leading the way. So this chart, starting with my left, is the overall numbers. So the first bar is who is fully vaccinated. The next one is partially vaccinated, then not vaccinated, and prefer not to say. And again, this was an optional survey, so and completely anonymous. So again, just above the state average, we've got nearly 7 out of 10 of our educators who are fully vaccinated and very safe to be around children. In our schools, so often our preschool or early child special education, you've got about 72% of educators fully vaccinated. In our child care centers, we've got about 65% of our educators vaccinated. And then for Head Start, about 66% of our Head Start educators are vaccinated. And then in our family day homes, really exciting to report that 83% of our family day home educators have gone out and gotten fully vaccinated. So progress, it's exciting to see, particularly because we know that all of these educators are around very young children who are not eligible yet for the vaccine, to see them creating that cocoon of sorts in terms of safety around children. Also know that there's some work to be done. We would like for all of these bars to be closer to 100% where medically possible, because we know that's the best way to keep our littlest learners safe until they're eligible for vaccines. Next slide, please. So when we think about that shared challenge of how do we vaccinate every educator, and I really appreciated hearing from Megan on some of the different thoughts, incentives, reducing barriers, thinking about kind of asking why folks are not getting vaccinated and then potentially taking stronger steps. We also asked in that same survey, well, what's holding folks back? And this chart reflects just the folks who said, I haven't been vaccinated yet. About half of them, and remember this is a sort of a smaller subgroup, but about half of them said they didn't want the vaccine. And that might be a harder one to work with. That might require a mandate. But there were also other reasons in areas where we think that progress can be made. first of the kind of the next biggest category was safety concerns. And I just want to note again that this week, as Dr. Avula noted, we saw the FDA give full approval to the Pfizer vaccine. And so that maybe potentially with some education and support could encourage more of those early childhood educators to get vaccinated. Some portion had COVID, and why they have some immunity, again, whether it's boosters or just making sure that folks are clear that just having COVID does not give you the same level of immunity that getting the vaccine does. And so really kind of encouraging those folks, helping them get more information, maybe connect with a doctor, health expert, and sort of showing them the benefits of getting the vaccine, even if you've already had COVID. Other folks might have a health condition, and for those, I think similarly, as Megan noted, I'm neither a doctor nor a lawyer, so I think to sort of finding out who may have health conditions and making sure they're talking with their doctors. Then there's other prefer not to say. One of the things that I'm really excited about, and I think this is in due partnership and to the incredible folks on the phone, as well as our partnership with the Early Childhood Foundation, we have really reduced many of the access issues. So when you look at how few educators are saying, oh, it was difficult to travel, I don't know where to go or how to get one, there's just all these barriers, that's a very teeny percentage of the folks who are saying that they're not vaccinated. So everybody should give themselves a real kind of pat on the back in terms of, at least for those folks where it felt like it was safe, right, that we've been able to make sure that they can access these vaccines. The challenge ahead of us now is to really work on some hearts and minds around addressing these safety concerns, making sure folks understand that just having COVID is not as much immunity as the vaccine, and then thinking through kind of maybe digging deeper to find out why folks don't want it, particularly when we know that the hospitalization and severe illness rates are just so much better if you are fully vaccinated. If you want to, we can click on this and we'll give this link. Very easy if you've not yet received a vaccine, or if you have somebody, a staff member who is interested, you can click Vaccinate Virginia. It's free, it's safe, it's effective, very easy to sign up all over the state. We do have much more supply than is being asked for right now, so this is the time to go out and get your vaccine. Next slide, please. And then this is the other key piece, I will say, sort of in terms of what we're hearing right now. I know that Kathy asked some questions about this to Dr. Filano and Dr. Avula, but absolutely the kind of the challenge right now that programs are facing across schools, Head Start, childcare, family day homes is quarantining. And so just another plug for vaccines, particularly knowing how challenging the workforce pieces are, is noting that if you have fully vaccinated staff, it completely changes oftentimes the kind of the guidance on quarantining. And so we know from the school perspectives, we've had some challenges where it's not been the kids that are quarantined, it's the educators, and there's not enough staff to we've actually had to close some schools. And so really starting to think through, and working with your employees, with your team members, because if you can get all of your staff fully vaccinated, it significantly reduces the risk of quarantine. And we know that's a real challenge. And we also know that, again, all of the kids in the below 5 set are not yet eligible. And as Dr. Avula noted, may not be eligible for a while. And so we have to get all of the adults vaccinated, one, to keep them safer. And that's absolutely the kind of the most important thing. But two, the new term I've heard is cascading quarantining, right? Where this thing is so contagious that it's almost like a whack-a-mole situation in terms of different kids, different settings are getting it. Your staff might be exposed in different aspects of life now that their kids are back in school, for instance. And if you have unvaccinated staff and they have a contact, as Laurie noted, that's 14 days, right? And as you're thinking through, how do you make sure already you're sort of stressed for staffing, having a series of 14-day quarantines or even 10-day quarantines is extraordinarily disruptive. So just one more plug as you're trying to work with folks to get vaccinated, but We need to keep our very valuable employees safe. We need to provide a cocoon for our littlest learners who cannot be vaccinated. And we also, in order for us to kind of stay open and operational throughout this fall, winter, and spring, we've got to be able to kind of mitigate, right, when there are inevitably going to be cases among our unvaccinated populations, which now more than ever kind of includes kids. We've got to figure out how to get all of our sort of school-based and childcare center and Head Start staff vaccinated in order to kind of keep just continuity of care and education. We've seen in the spring of 2020 and over the course of the last year that kids struggle, mental health, other emotional and behavioral issues, and do not learn as much when there are these constant disruptions. And so we can't make COVID go away, but we can take steps by wearing masks and really working with our little guys to wear a mask. My 3-year-old is now back in preschool, and we're putting on a mask, and he's doing great. It took a little while to get adjusted to it, but he's doing great with it. Wearing masks, encouraging vaccines, maintaining distance and cohorting where possible, making sure we're not sending sick kids or adults into care or education, and then again working very closely with your local health department, when there are concerns to be able to address that. So we'll go to the last slide, Kathy, and then I'll see if I can figure out my audio for questions. But we just also wanted to include, and we'll share these slides afterward, just the specific links. I know everybody is drowning in information, and if you go to the CDC website, you could probably lose an afternoon there, and nobody's got time for that. So we just wanted to summarize the key expectations on masks, as well as a few other links. I felt these helpful in terms of figuring out different strategies for getting kids to wear masks, and then just a little bit more information about the survey.
Okay, I think Jenna's going to try to get her audio working properly. Jenna, can you hear? Jenna,
Kathy, I've sent her a chat message to go to the audio section in her control panel and select a speaker. That's probably what she needs to do. So I don't know if anyone can email her or text her that as well.
I did text her that. I think that's what she's trying to do, but it doesn't appear to be working. I'm going to actually try to text her a question that's come from the panel. We're actually getting really close to the end point, but so a lot of great questions have come across. Let me just see if I can get one to her that she can speak to. Jenna, are you able to hear us? It looks like you're muted. Oh dear.
Yeah, she also needs to enter her audio pin, so I don't know if she's trying to do that.
Can you send her pin in the chat?
I did.
Okay.
You all hear me now?
Yes.
Excellent. So I saw the question being about sort of why is there a difference between K-12 schools and the child care setting. So the K-12 school requirement is relatively new. It's for children 2 and above in all of our private and public K-12 schools, and came from the Department of Health. There has been additional consideration about child care settings. I think one of the things that we are currently looking at is implications for our, particularly our littlest learners and how long. So if you'll remember, prior mandates of mask mandates have normally focused on 5-year-olds and above, right? And we know that we've had multiple settings where 4- and 5-year-olds, and 5-year-olds in particular, have worn masks for long periods of time. Masks have been recommended and in often places not necessarily worn by 2- and 3-year-olds for really long periods of time. And we know we have a large number of 2-year-olds and 3-year-olds in care, and this isn't just an episodic visit to the grocery store, right? This is talking about multiple hours, sometimes 6, 7, 8, 9 hours. And so one of the things that we've been working very closely with the Department of Health on is sort of really looking at the kind of implications and, where there are, where there kind of, there's evidence that we can sort of do this and manage that, a mandate limits all discretion at the program level. And so we're trying to be very thoughtful about that. We also know and have heard from providers too on kind of the, sort of that they appreciate some of the discretion, mostly with the littlest learners. And so I know for those of you who are working directly with 2- and 3-year-olds, full hands down, this is a hard group to keep them on. And I know, for instance, when I got my guidance from my school most recently, they were like, no mask break, like that's the deal. It's the state mandate, like we're not going to touch that. I also know that I've heard from childcare providers and those who have classrooms of 2- and 3-year-olds that those mask breaks, with distance are just really, really important in terms of being able to get the kids to wear it most of the day. And so it's something we're looking at, but largely has to do with 2- and 3-year-olds and just the long periods of time in which they're in care and just wanting to be as thoughtful as possible. So if that does change, we'll let you know. But right now, there's a little bit more discretion in those childcare settings, particularly for those littlest learners. Lastly, there was a question about will the state require vaccines for childcare educators? I can't say that that's impossible. I will say our focus right now is on encouraging this. We have an array of public and private programs. We know that there are different issues that are keeping folks back, and our goal is on kind of incentives and encouragement as being the sort of the most expeditious way to get our adults vaccinated. So there, certainly it's not in the immediate horizon. Thanks, Kathy. Let me turn it back to you. I know we're just at time.
Thank you so much, Jenna. I really appreciate all the great information. There are many more questions that have come across, but our time is up today. We will be circulating the recording from today as well as the slides, and you'll be able to see all the links, get to all the links to the information. Appreciate everybody spending so much time with us today and the sharing of such good information. I really appreciate your interest, your questions. And be safe, and thanks for all you do every day. Take care.